Welcome. My name is Dr. Stephen Sanet. I'm an American osteopathic physician, and I'd like to talk to you today about fibromyalgia. Fibromyalgia is common to everyone in the treatment world, in the musculoskeletal world, in the medical world, a very common condition we're dealing with all the time. Fibromyalgia is going by many, many names, and I've just listed a few of them: fibromyositis, fibrositis, muscular rheumatism, psychogenic rheumatism, polymyalgia rheumatica, neurasthenia, and the list could be quite large. The term fibromyalgia was coined in 1981. While I was in medical school, they established a criteria for it in 1990, and this has been updated in 2010. But it remains with a persistent lack of objective diagnostic or pathologic findings. We all know the fibromyalgic patient as someone who has just global complaints in many body systems with many, many different features. The epidemiology, according to the American College of Rheumatology, estimates 2 to 8% of our population, American population, is affected by this, females twice as often as males, and that it is undiagnosed in up to 75% of the population, meaning that 75% of the population may fit into the current category of fibromyalgia, but have not been told that. Approximately 10% are functionally disabled, that their condition is so difficult that they are actually disabled. Fibromyalgia does not discriminate. It's stratified across race and ethnicity. Everyone is affected by it. There is a rather ubiquitous nature of the complaints that don't fit into any easy category. The signs and symptoms they're varied from patient to patient. There is no standard set of multiple systems or multiple complaints that we can quantify and say, well, this means fibromyalgia. Some of the difficulty is that patients have various ideas reinforced, negative ideas reinforced with them with previous healthcare professionals, which further adds to their difficulty. There is about a third of them have some history of trauma, a third the history of a viral infection, and a third no clear etiology. But to be clear on that, to say that you have a trauma history, that you can relate a trauma to the onset of your symptoms is also not clear that that was the cause of your set of complaints that we are calling fibromyalgia, as you'll see as we move further into the diagnostic criteria. Also, the viral infection. Often if there's a viral infection that can be blamed for the onset of the fibromyalgia complaints, it's not conclusive that that is actually what happened. We don't have a clear pathway to that. In 1990, the American College of Rheumatology determined by 18 points in the body that are outlined in the diagram here, that if you had pain in 11 of these were tender or painful, then you were afflicted with fibromyalgia. And it's a very non-specific type of diagnosis. They were just looking for pain that was affecting multiple areas of the body. And this paradigm held until 2010. In 2010, I think they made it even more complicated. The American College of Rheumatology decided to make this the diagnosis of fibromyalgia based on what they call a widespread pain index and a symptom severity scale. So they divided the body into 19 general body areas. And if a patient has experienced pain in the preceding 2 weeks in a certain number of these, and the pains are a certain severity of these, then they classify you as fibromyalgia. So what they're looking for is the severity scale is from 0 to 3, kind of a simple scale, in 4 categories for each of for someone complaining of fibromyalgia or suspected fibromyalgia. 0 to 3, as far as their affected fatigue, waking up and still feeling tired, we call unrefreshed waking. their cognitive symptoms, how clearly they feel that their cognition is, and general somatic symptoms. So they have a severity rating for each one of those. If the aggregate of those four categories is then given a number on a scale of 0 to 12. So the new criteria uh, for the for the positive diagnosis of fibromyalgia is a widespread pain index in greater than 7 areas or equal to 7 or more areas of pain, and the severity scale being greater to or more than 5, or feeling widespread pain in less than 7 areas, 3 to 6 areas, but having a severity scale uh, equal to or greater than 9. Again, this is still a nebulous um, diagnosis. Uh, this doesn't clearly tell you what's going on. It just tells you that they have some sort of global type of pain. Uh, the symptoms need to be present at a similar level for at least 3 months, and no other underlying disorder that they can say, well, this is the cause of your uh, pain. So if they have no other way to explain it, then you fall into this huge, huge category of fibromyalgia. Some common comorbidities with fibromyalgia: irritable bowel syndrome, psychological issues, which we'll look at. We'll look at each of these separately. Chronic fatigue syndrome and headache. Often the patient who has complaints of fibromyalgia is going to have one or more of these uh, comorbidities. Irritable bowel syndrome. Well, let's look at what that means. Irritable bowel syndrome in the West, and I say in the West because in North America, Europe, places that are very affluent financially, the diagnosis will be made based on diarrhea, constipation, one or the other or both, plus abdominal pain and a negative colonoscopy. In countries that don't have the access to expensive healthcare, they may not be doing the colonoscopy. So it may be made on just the other findings. Uh, in North America and Europe, it's very likely you're getting a colonoscopy so you can rule out that you do not have irritable bowel complaints because of cancer, Crohn's disease, or ulcerative colitis. Those are things we want to be able to rule out. So if there's no other etiology for it, you don't have ulcerative colitis, Crohn's disease, no cancer, and yet you have these complaints, we call it irritable bowel syndrome. We have no other reason for it. Um, in the musculoskeletal world, I would consider facilitated autonomic nervous system due to chronic pain to be an etiology for irritable bowel. In the traditional medical world, I think that will be overlooked. In the musculoskeletal world, we consider the facilitated segment. If you have, for example, chronic low back pain, and the segments, their neural threshold can be changed in the lumbar area, they also share some commonality with origins of splanchnic nerves. It may be that your autonomic nervous system is being upset by the constant affector input to the autonomic nervous system from the somatic dysfunction causing a visceral dysfunction known as irritable bowel syndrome. So it can be a little bit more complicated, but as I said, in the traditional medical world, I don't think there's a rapid link to irritable bowel and low back pain. In the musculoskeletal world, we do see it quite constantly. Another comorbidity is going to be psychological: anxiety, panic, depression. These are seen as comorbidities that are going either as because of the fibromyalgia or as a consequence of the fibromyalgia. I think it is quite a reasonable consequence of having global pain or global dysfunction, restricted range of motion, and so forth. So it becomes difficult to tell, did the psychological issues precede what is now being labeled as fibromyalgia, or is the fibromyalgia and the global pain and restricted range of motion, is that what is preceding the depression, or are they, um, you know, co-simultaneous? It's hard to tell. Chronic fatigue syndrome. This is another very common comorbidity with the diagnosis of fibromyalgia. And it's often another very mysterious etiology with various theories that are not conclusive at all. So if you've had the common viral theories, Epstein-Barr, human herpes number 6, Coxsackie virus, if you've had one of these viruses very often, if you do the traditional medical route, they will say, well, you've had that virus and that's why you have these symptoms. What I said to you earlier in this lecture, it's not clear that because you had an Epstein-Barr virus, that is the reason for your current situation. Human immunodeficiencies, hormonal imbalances, these are reasonable reasons also to be suffering from chronic fatigue. Physical and emotional trauma. These are often difficult to determine that was the cause. Sometimes people don't recall certain physical traumas. Sometimes emotional traumas they don't really want to discuss with you. So again, these are very unclear. What is clear to me, that is, if you have what we're calling, or what you have been labeled as fibromyalgia, then if you have a lot of pain and decreased range of motion, then for you, you have an increased biomechanical cost for you to do your ADLs. ADLs are your activities of daily living: getting up, putting on your clothes, doing the wash, brushing your teeth. Everything costs more energy for you to do it because you have pain and restricted motion. So to me, it would appear that it would be quite natural for you to be much more tired than someone else. I see it as a natural comorbidity. So what is not clear is whether one precedes the other, the idea of chronic fatigue, or because each one would exacerbate the other one. Headaches, another very common comorbidity. Again, if I look at the idea of increased biomechanical demands due to pain and decreased range of motion from fibromyalgia, then if you happen to have migraine headaches prior to being diagnosed as fibromyalgia, they're very likely to be worse. Tension headaches are likely to be a sequela of the same symptoms associated with increased biomechanical requirements. And tension headaches will also exacerbate a migraine headache that pre-exists it. So these are comorbidities, but they don't clarify. They're difficult to clarify the instigating etiologies. So what's the answer? No clear diagnosis leads to no clear medical treatment. Literally, there are so many classes of medication that are used to treat people that complain of these symptoms. You can go through class by class by class that they will try. Antidepressants, SSRIs, tricyclics, very irresponsibly, opioids, other painkillers, non-steroidals. What I found to become popular about 25 years ago, people were starting to play around with neuroleptics, and I find they're very popular today, to use neuroleptic medication, which really have an indication for seizure disorders. And I find these to be, if they are not helping you, then they are hurting you. What neuroleptics do is gabapentinoids, things like Lyrica is very popular today. What they do is they change the neural threshold for stimulation. The idea being that if we raise the threshold for neural stimulation, then you will not feel the pain or the discomfort that you're feeling. But the side effects are often very, very terrible and quite a long list. One of the very common side effects happens to be massive weight gain with many of the neuroleptic medications. And if you have depression, and if you have global pain, and if you have chronic fatigue, adding on a lot of weight is going to make all of this worse. So the medical strategies, they span the entire spectrum of everything that I've been trained in medicine pharmacologically. And it literally becomes a fair amount of guesswork to see if one of these things makes you better. My personal osteopathic approach, when I'm considering someone that has what I consider fibromyalgia to be a multifaceted complaint set, it is critical to know their history in as much detail as possible: duration, onset, nature of the pain. And in this case, I find an exhaustive history to be very, very important, because re-education is one of the keys in fibromyalgia. It's paramount. Often the patient that I see for fibromyalgia or that fits into that complaint set has has been reinforced by other therapists that there's no resolution to their problem and that they need to live with it. And they've been promised that there's no cure. They have gone through all the possible pharmacologic options and nothing has helped them. So when they do feel better, it's very common for them to say things are exactly the same. And then I need to point out as a therapist that it's not the same. The headache is not lasting as long. You're not having it every day. You're not as tired as you were. You're doing more activities. Any way that you can show them a change in their body, for me, fibromyalgia is a massive set of complaints. The more complaints you have, the more likely it is that I'll be able to do something to change some of these complaints. Maybe all of them, maybe a lot of them, maybe only a little bit, maybe nothing. But if I can change anything, I need you to see that your body is capable of changing because it has been reinforced that their case is without hope. So I'm not lying to patients and I'm not creating false hope. But my experience with fibromyalgia patients is by and large, most of them can have a positive response to osteopathic treatment. That response can be small, it can be, moderate, it could be a wonderful experience. But the difficulties in re-educating the patient, not in lying to them, but in opening them up to the possibility that they can be well. And as a therapist, I believe you need to see that possibility as well. I thank you for your attention and look forward to the next lecture.